Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling hemophilia. So as always, let's get started with our practice question. The nurse is assessing a child suspecting of having hemophilia A. Which of the following findings would support the diagnosis of hemophilia A? Select all that apply. So we have a prolonged activated partial thromboplastin time. That's abbreviated APTT. B, thrombocytopenia. C, hematuria. D, a prolonged INR. That's international normalized ratio. Or E, an increased red blood cell count, RBC. So as always, tuck away what you think that right answer is, and we will circle back to it at the end of the episode. But first, let's talk about hemophilia. This is a disorder that turns what should be a quick clotting process into more of a kind of slow motion sort of emergency. You'll probably have heard it called a bleeding disorder, but to understand it as a nurse, you need to understand what happens when our body needs to stop bleeding. This is our clotting cascade. It is basically an intricate chain reaction that keeps us from just bleeding out every time we get a paper cut. So let's just start there. Let's start with a paper cut. A blood vessel is injured and your body jumps into action. First thing that happens is platelets rush to the scene. Your platelets you can kind of think of as your first responders. Basically, they clump together and form a temporary plug. We call this the platelet plug. Now, that plug is not strong enough to hold without reinforcement, so other clotting factors come in. These are a series of specialized proteins. They are made in the liver, that's important, and they work together to create something called fibrin. I think of fibrin as like a mesh, and that's going to go and stabilize the clot, again, so we stop bleeding and we don't bleed out from said paper cut. Now, the key part to understanding hemophilia is that we have lots of different clotting factors, and each one activates the next. It's kind of like a relay race. And if one of those clotting factors or a runner in the relay race, drops the baton, the race stops right there. None of the other runners can go. Okay. So, like domino effect, if we don't have one of the clotting factors, we are in trouble. And that's what we see happening in hemophilia. Okay, so hemophilia A is a deficiency of the clotting factor known as factor VIII. When we don't have enough factor VIII, the clotting cascade cannot move forward. Fibrin, that mesh, doesn't form, and then the bleeding is going to continue much longer than normal. Now, I think it's important to note that hemophilia is almost always X-linked recessive. So primarily, it's going to affect males. Females are typically carriers because they have two X chromosomes. But if the male just gets one X chromosome with that X-linked recessive trait, then he will have hemophilia. Now, there are different degrees of severity, and that's going to depend on how much factor VIII activity there is in the body. Someone with mild hemophilia might just bleed excessively after like a major trauma or surgery. They have some factor VIII, just not a totally normal amount. A more severe case of hemophilia, we might have pretty much no factor VIII, and we can get spontaneous bleeding even without injury. So obviously, that can become a really big emergency. So let's go ahead and walk through a case study so we can kind of see how these symptoms present and of course, what we're going to do about it as nurses. So you're working in the emergency department today, and you have a 6-year-old boy come in. He took a tumble on the playground. His mom tells you he fell on his knee, his left knee, and there aren't any open wounds. It's not like he has like a gash across his leg that's pouring out blood. He fell, she took him home from the playground, and then she goes to unbuckle him from the car seat, and his knee is swollen. She's like, it's like double his normal size. He says it hurts. He can't straighten it. I tried to touch it and he cried out in pain. So she thinks, maybe there's a fracture or a muscle tear or something going on internally. So you go ahead and go on in the room. You're going to do your exam, and we see that the vitals are stable. There's no other trauma on his body, but he has a very swollen left knee. It is warm, tight, and visibly swollen. So, the finding here that your brain should be thinking about is something called a hemarthrosis. So, heme we know means blood, arthrosis, that's a joint. Think like arthritis in our joints, arthra, that's kind of the word that's going to make us think joints. Heme, arthrosis, we've got bleeding into a joint. So it's warm because there's blood back there. It's tight because that blood is filling up that cavity, that joint. That's what's making it swollen and tight. It's going to be very painful. He's not want to move it, bend it, straighten it. So that all lines up. You'll also note there aren't cuts or lacerations. So we don't have external bleeding going on in this specific client. We certainly can with hemophilia, but the bleed is happening inside. It's happening in his knee joint where he fell and bumped it. So now let's back it up to our anatomy here. Let's think, does this make sense for hemophilia? Remember, in normal clotting, platelets go and form that first platelet plug, and then clotting factors activate. They go down that domino effect. One activates the next in our relay race, and it ends with fibrin, that mesh clot that's going to stabilize our bleeding. With hemophilia, we are missing factor VIII. So the body cannot form that strong fibrin mesh. One of those clotting factors in our relay race is gone. The baton does not get handed to our next runner, and we can't make that clot. So when this kiddo fell and bumped his knee, he had a small tear in a blood vessel down internally in his knee, and he kept bleeding. The joint cavity filled with blood. That caused the swelling, the warmth, the pain. It wasn't infection, it was just pooled blood. That's what we call that hemarthrosis. So now you're going to need to do a little bit of investigative work. For a 6-year-old, we've got hemarthrosis in the knee. You should be thinking, okay, that's not normal. Most 6-year-olds, when they fall and bump their knee, don't get swelling, bleeding in the joint. So we got to dig a little deeper and see about other symptoms. You want to ask about bruising. Mom confirms, yeah, he bruises really easily. It doesn't take anything to cause a bruise. You want to ask about things like nosebleeds, bleeding in the gums, prolonged bleeding after a minor injury. I usually give the paper cut example. Any of those things are red flags. Remember, especially in a boy, they are much more likely since this is X-linked recessive. So again, that's nosebleed, bleeding gums, prolonged bleeding after like a paper cut. The hemarthroses we mentioned, any of those things are not a normal bleeding response. So that's going to be the trigger when we kind of got that history that said, we need to do some lab work here. Okay, y'all pause. What labs do you want to look at when we are trying to investigate if this child maybe has hemophilia? We're not sure his blood is clotting like we want it to clot. We need to get coagulation studies. Most nurses are going to call these coags. They go in a little blue top tube, and these include your APTT. Remember, that's your prolonged activated partial thromboplastin time, APTT. We're also going to want to get an INR, a prolonged international normalized ratio. That goes with your PT, your prothrombin time. Those two kind of go together. And that's going to give us information about both the internal and the external clotting cascade. We basically want to know what's going on in there, how fast is that blood clotting. The lab that tells us that are those coags, PT-INR, and the APTT. The other thing that we want to get, if you remember, our kind of first responders were those platelets. So we do want to look at a platelet count as well to make sure there are enough of those platelets. And as you can imagine, if we don't have enough platelets, that first responder not going to be able to form that platelet plug. That can cause increased bleeding. So that decrease in platelets is something called thrombocytopenia. That can happen in cancer or bone marrow problems. Another reason we can get prolonged bleeding, not hemophilia. With hemophilia, we are going to expect that PTT, that partial thromboplastin time, is going to be really long. That's because that partial thromboplastin time, that PTT, that is measuring the intrinsic coagulation cascade, which is where all of those different clotting factors run their little relay race and end up causing that fibrin clot. In hemophilia, we're missing factor VIII. We don't pass the baton off. We don't get the fibrin clot. So that PTT is going to be way longer than normal. It is taking a super long time for that intrinsic pathway of coagulation to work. It's basically not working. The other type of coag is our PT, that prothrombin time, which remember goes with your INR, your international normalized ratio. And that is measuring our external pathway of blood clotting, which is not affected in hemophilia. So if we're looking for a diagnosis of hemophilia, we're doing our coags. What we are looking for is that PTT is long, internal cascade is not working, but the PT-INR is fine. The external cascade is fine. And the platelets are normal. They can form a platelet plug. Their platelet count is A-OK. It is the fact that they are missing that factor VIII that means their intrinsic cascade can't work, so their PTT is prolonged. So once you have those labs and that diagnosis get confirmed, what do we do about it? What is our treatment plan, our priority as a nurse? First, we are going to replace the missing factor. That is the name of the game. Really, your key takeaway here is if they don't have enough of factor VIII, we need to give them factor VIII. Let's replace the missing coagulation factor. So we have a factor VIII concentrate that essentially just provides the body with that missing runner in the relay race and allows the bleeding to stop. And we administered that. We went ahead and did it in the emergency department. Within hours, the swelling of his knee began to plateau. It's not going to totally go away. That's going to take some time for all that blood to resorb, but it should stop getting worse. Okay, what else do we do in this acute phase with this hemarthrosis? We want to immobilize the joint and follow RICE, rest, ice, compression, elevation. We have to do all this very gently, no intense compression, because we don't want to cause any more trauma. So any client that you have with hemophilia, bleeding precautions. We don't want any IM injections, no unnecessary sticks or needles. We really got to limit needle pokes. Definitely nothing that increases bleeding. Aspirin or NSAIDs are going to be big no-nos in a client with hemophilia. That can worsen the bleeding because it affects their platelets, and they've already got good platelets going for them, so we don't want to ruin a good thing. What we can use for pain is acetaminophen. That's your Tylenol. It doesn't interfere with clotting, so that is safe. Now, this is a lifelong diagnosis. We do not have a cure for hemophilia A, all right? It's an X-linked recessive disorder. He has had this since birth and he will always have it. It is going to be about managing complications and preventing those complications from happening. So we want to explain what is going on, helping the mom, the dad, the support system understand the diagnosis. Let them know it is genetic. How are we going to manage it long term, manage bleeds at home? A big thing is going to be when he starts bleeding, how do we stop it? Applying pressure. When do we call for help? And he is going to get an outpatient referral to a hematologist so that we can manage his factor VIII levels. He's going to need infusions, especially if he has any sort of trauma or if a surgery is planned. So those are kind of your big buckets, okay? You're going to replace what's missing. We don't have factor VIII. Let's give him factor VIII. And then we are going to prevent trauma from occurring. So all about prevention, bleeding precautions, taking things slow, being careful, knowing what complications to watch for, like the bleeding gums, the nosebleeds, the hemarthrosis, and calling for help when needed. So all that being said, I'm going to bring us back to our practice question. Remember, it is about the labs. So think about what is going on inside your client with hemophilia and see now if you can get to the right answer and understand why. Okay? The nurse is assessing a child suspected of having hemophilia A. Which of the following findings would support the diagnosis? Select all that apply. We have A, a prolonged PTT, B, thrombocytopenia, C, hematuria, D, prolonged INR, and E, an increased red blood cell count. All right, which ones are correct? Remember that the hallmark diagnostic finding of hemophilia is that prolonged PTT. So A is correct. That lab test tells us how well the intrinsic pathway of our clotting cascade is working. And that is where factor VIII comes to play. In hemophilia, we don't have enough factor VIII. That clotting takes longer. We see a long PTT. What we do not expect to see is that those platelets go down. B, thrombocytopenia, incorrect. Or that extrinsic coagulation cascade is affected. So D, that INR, measures the extrinsic coagulation cascade, and we would not expect that. Those two values should be normal. They're not the problem in hemophilia. So we have a long APTT, but we have a normal INR, a normal platelet count. Now, what about C, hematuria? That's not something that our client presented with, but could our client, if they're not able to stop bleeding, end up having blood in the urine, hematuria? Absolutely. This is when we have microscopic bleeding and it ends up in the urine. We can absolutely see that with hemophilia. That goes right along with our other clinical signs like the hemarthroses, the bleeding gums, the nosebleeds, etc. Watch out for those clinical signs. And lastly, E, the increased red blood cell count. I think you know that is also incorrect. RBCs are going to stay normal, all right? Hemophilia is not anemia. We've got plenty of red blood cells. We don't have enough of factor VIII, so we can't clot effectively. All right, so key takeaway here, wrap it up. Hemophilia A, we have prolonged PTT. Our platelets are normal. Our INR is normal. Our red count is normal. But we do get those signs of internal or prolonged bleeding. So watch for hematuria, watch for hemarthrosis, nosebleeds, etc. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.